Patel, give us the answer.
Thank you. Thanks, everyone, for coming in today. So it's sort of a loaded topic because I think if I got 10 interventionalists in this room, I think we'd get 10 different answers about what the right thing is to do for these patients. But I'll show you, sort of give you the, this isn't kind of moving, it's not really moving forward.
Try it again.
Okay, so these are my disclosures. So I'm going to break these up into two different topics because they don't kind of really go together. So for accessory renal arteries and EVARs, it occurs in about 15 to 30% of patients of the general population. I mean, it really can represent two different problems. So you can have an accessory renal artery that arises from the seal zone. So the question is, will covering lead to decreased renal function or uncontrollable hypertension? And then you can have a second set of patients that basically the accessory renal artery rises from the aneurysm sac itself. And then the question really becomes, is this going to lead to maybe potentially a significant type 2 endoleak down the road? So arising from the seal zone, it's a slightly easier problem, if you want to put it that way. But basically, if it's our general gestalt, at least in my mind, is if it's bigger than 4 millimeters and it's really supplying a perfusing a significant amount of the kidney, I would consider actually some sort of preservation. And now basically that relies on either some sort of fenestration or reimplantation. If you do have to cover one that's smaller, actually, these guys in JVS published in 2013, they actually found that there was no real difference in systolic blood pressure or renal function, whether you covered it or preserved it. So I don't think it really makes that much of a difference for some of the smaller renal arteries. Actually, interestingly, if you do cover it, they only found that only about 2/3 of the patients actually had an infarct. About 1/3 of the patients didn't actually infarct their kidney or that portion of the kidney. So I think it does. If it's bigger than 4 millimeters, our general gestalt is to do some sort of reimplantation or preservation. So the more troublesome one is actually the ones arising from the AAA itself. Again, if it's perfusing a significant amount of renal parenchyma, if I feel that it's going to change the patient's overall kidney function, then I consider some sort of reimplantation or sort of dealing with it that way. If the concern is really of a type 2 endoleak, that's sort of an interesting problem there. So most commonly, it represents the outflow of an endoleak. So basically, it's not really causing an inflow, it's actually acting as an outflow. So you have a lumbar either that now is filling retrograde, and then the renal is acting as the outflow, or an IMA, and so forth. Usually seen in renal arteries, accessory renal arteries bigger than 3 millimeters, but I'll be honest, we have seen them even in smaller accessory renal arteries as well. It can represent the inflow, but I'll be honest, I've never really seen one represent an inflow and actually pressurize the sac, so have a sac grow. But I'm sure there's probably someone who has a case somewhere that they've seen it. So I'm going to show you a case here just of how we dealt with it. So an endograft placed about 5 years prior. I'm going to see if I can pause this. And you can see here's the endoleak here. I don't know if that projects very well. And you can see basically here's the accessory renal artery filling the lower pole of this kidney. So again, when we did the aortogram, hopefully this will show up. You'll see here's the arc of real end, here's the endoleak, and actually here's the accessory renal artery acting as the outflow. So again, we basically catheterized all the way around through the IMA into the accessory renal artery, embolized that with interlock 018 coils, and then basically used onyx to fill up a little bit of the sac and sort of plug up the IMA there. So again, I'll sort of rehash what we do at the end, but basically if I think it's going to be a problem in terms of renal function, I embolize it. If it's smaller off the sac and it's easy to get into, I'll try to get into it and embolize it preoperatively. So the IMA and EVAR, so persistent flow in the IMA is probably the most common cause of type 2 endoleaks after EVAR. There are some studies to show that actually it can transmit near systemic pressure into the sac, so it can actually basically repressurize the sac. It's difficult to determine which IMAs should be embolized preoperatively. I don't think I've seen a good study to say, okay, if it's this big or it looks like this is the ones to embolize. It really sort of comes down to how you feel. In terms of the way we look at this, we actually did a study, it's a retrospective review. Basically, we looked at pre-op angiograms in patients where the IMA was visualized and prophylactically embolized. And that was, compared to patients with patent IMA on CTA, but we couldn't see it angiographically. And that basically we had follow-up CTA at 1 month, 12 months, and then yearly thereafter. So basically 104 patients, IMA patent on angiography, 100 were successfully embolized, and 41, actually we had 2-year follow-up for 41 patients, and there were 148 patients in the other arm. just in terms of complications of embolization, 7 patients reported to the ER within 48 hours for abdominal pain, all self-resolved, none of them requiring any sort of intervention, basically a little bit of hydration, some pain control, and they were fine. It possibly related to collateral maturation. We didn't actually go back and look, we should, to see if we actually did an embolization of the hypogastric at the same setting, but to be honest, I don't remember. So the 1 month results in the non-cohort arm, you had about a 45% presented with some sort of endo leak, and then about a third of the patients in the embolized arm had an endo leak. So even though the numbers aren't that great, there was a significant difference in number of endo leaks. That in itself is not really a big deal to me. I think this is sort of a more important slide here. Basically, in the non-embo cohort, there was a 5% overall reduction in the aneurysm sac volume. When we actually took it in vitro and actually did sac volume measurements, 23 of the 42 had decreased volume, about half, but about 10%, 11% basically. 19% patients, with increased sac volume, which is with a median increase of about 11%. On the embo arm, there was a 17% overall sac volume, so they had a greater overall reduction in the sac. There was actually more patients that had decreased sac volume and a smaller number of patients that had decreased sac volume with a smaller amount of increase in the volume. In terms of reintervention rate, again, the non-embo arm, 15 patients required some sort of reintervention, whether that be an angiographic embolization, which actually all of them were angiographic and embolization. In the embo cohort, only 1 patient required a reintervention, and that's out to 2 years. So preoperative embolization of the IMA basically observed decreased incidence of type 2 endoleaks, significant reduction of the aneurysm sac volume, and reduced secondary interventions to treat type 2 endoleaks. So basically, this is sort of what we do. So accessory renal arteries cause type 2 endoleaks if not significant supply to the overall renal function. We tend to embolize the ones arising directly from the aortic sac. IMAs, if they're sizable, if they look like they're relatively easy to get into on angiogram, we preoperatively embolize those IMAs. Thank you.